Edward, do you have a control where you can admit doctors as they join? I have to do that. Okay.
Yes, sir.
All right. Yes, we can get started, but just a lot of people coming in, and unfortunately, we need to have a second staff person who can do all that background work.
Okay. I'll make sure to edit that for the next one.
Okay. Thank you.
Of course.
Okay, welcome providers, RGCC practitioners. That's how you're known. It's registered RGCC practitioners. And I welcome you for a roundtable discussion. I'm facilitating, and we're going to cover the Onconomics, the Onconomics plus, Onconomics extracts plus, and Onconomics extracts. We're kind of cover the sensitivity, the cultured sensitivity, and then we will cover the gene expression at the next session, which is the third session of the roundtable. Okay. So what we'll cover today is a little bit different because in the past, you just need to know basically what will work and and then use that information to create a treatment plan. However, if somehow I'm not hearing you ask a question, let me know in the chat somewhere. I'll try my best because last time there was someone trying to ask a question and I didn't hear him. But again, it's something happened to my audio. But anyway, so the difference here is you're not only going to know like what would be a how this chemosensitivity works in terms of some of the methodology there, but also that's part of the deep dive, and you also know about how do you use that information to create a treatment plan, and this is more of a review for that because you guys already know, but we're going to get a little bit more fine-tuned because that's important to fine-tune just a little deeper, and then finally I'm going to show you a case study, a case report, or an actual case of a 5-year case. You can see what's happened in 5 years for that advanced disease. Because I see a lot of advanced disease, but this is one good one that you can really see everything applied. You're not just looking at the protocol schedule, treatment protocol, but you're also looking at how the SOTs work with this kind of case, because that's extra. That's something really nice to have, but not everybody will really need it if you have a good plan. But if sometimes you just want to really hammer this cancer, you might want to throw everything at it. And if that's the case, then just make sure it's the most effective one. And then, of course, you've got the infusion therapies. These are the added plus for RGCC, since they create that for all your patients individually. Okay. So I'm going to go ahead and share my slide deck here. I'll try my best to explain this, but I'm a lab person. That was my initial training into the healthcare. First 5 years, I was working for a hospital lab in Orlando and also in California. And these are big hospitals. And I was working in a stat laboratory, getting all these results. And I know a lot of this instrumental work and stuff, but with RGCC, this is different. We're looking at liquid biopsy, the latest in technology, dealing with mRNA, dealing with DNA, dealing with cell counts of cancer cells. These are advanced. I don't even understand it fully. So if I don't answer your questions, don't be surprised, because I am not working for the lab in Greece. I'm a clinician in clinical support team. Dr. Bynum can answer some of these questions. She has a lot of experience, way beyond me. She was my mentor. And then here I am, just, with experience over time. I've done over 1,000 tests, and I understand how this works. I'm starting to click in, but still, I am not trained in the Greece laboratory. Until I go there and see it for myself and actually watch each step, I can't describe it. And also, you got to understand, there's some things here you're not going to know, and you're never going to know, because if you knew it, you could start your own lab You know what I'm saying? This is proprietary, guys. You think Datar wants to know what we're doing? You
Sure.
bet. You bet.
Yeah.
Okay. You bet. That's why they criticize and that's why they say negative things, because they don't know what we're doing and they think what we're doing is focus, focus. We're not going to let them know. We can't. That's why we get good results, because they don't have what we have. So don't be surprised. I'll tell you as much as I know, and you will know that, but you're not going to know everything, and neither do I or Dr. Bond know everything. I just want to tell you that in advance. Okay. So let me go ahead and share this screen here. I'm going to tell you one thing, guys. We're all the same trained. Okay, let's treat each other the same way, because we're all RGC. We have the same baseline training. We're all the same. We're all learning. But I just want to say something a little positive. I see Dr. Wyndham here. It's something else. You've got to contact me frequently to help you. But she is going so fast in terms of growth. Unbelievable how she's showing me her plan, and I look at it and say, man, this is a great plan. She learns really quick. So I won't be surprised if one day you're going to hear about her, because she's getting good results. She'll be getting very good results. So,
Thank you.
All right. This presentation is relatively short because I'm going to answer your questions. We're going to go through some of your cases that you want to discuss, because this is, after all, a roundtable discussion. Okay. So let me share the screen now. I know that I'll be interrupted, but I'll still share. I'll still let people in. Okay, please tell me that you see this slide. Yes?
Yes.
Okay. So we're going to cover, like I said, the chemosensitivity or the viability assays. Okay. Now, where Onconomics is a viability is a test that involves viability assay, but these are all drug chemosensitivity. And I don't know of any doctor that is just going to order Onconomics unless that's all they do. No natural substance. All of us are going to be ordering Onconomics Plus, Onconomics extracts, and at the least Onconomics extracts plus, and at the least Onconomics extracts. These extracts right here do not have any gene expression or resistance factors provided. It's only the pluses. So it's either Onconomics plus or Onconomics extracts plus. So you need to make sure that when you do a follow-up Onconomics 9 to 12 months later after the baseline, then you order the Onconomics plus or extracts plus, one of these two. If a patient is no longer on chemotherapy or any conventional treatments, you may just order the Onconomics extracts plus, because really, if you have the drug chemosensitivity, what are you going to do with it? Oncology is done. Okay. But in the beginning, always order Onconomics plus, because no matter how a patient says, hey, I don't want drugs, I don't want anything to do with drugs, still order the Onconomics plus. You're responsible to know what is available out there. And if you didn't know that, then I'm sorry, you might be questioned down the road on why did you not refer to oncology. Okay. So here's the general. This is the general kind of like what happens in the lab. So it's a 6-day efficacy culture in 12 plates treated with a specific drug concentration. And they do the cell viability by flow cytometry, and they determine the percentage of living, dead, and dying CTCs. Okay, the percentages are determined. It's called cell death rate. That's what's reported, percent kill, percent cell death rates. The controls, they're using untreated cells incubated in the presence and absence of chemo drugs and cell-free counterparts. And the classification then is that if it's less than 35% cell death rate, it's not a sensitive drug. If it is between 35 to 80% cell death rate, it's partially sensitive, and if it's greater than 80%, it's sensitive. That's the chemo drugs. Okay, we're not talking about the targeted drugs yet, or the natural. This is the chemo drugs, like the alkylating agents and so forth. So the chemosensitivity testing it's an ex vivo study. Okay, it's done on a culture and sensitivity testing with the CTCs introduced to drugs or other biological modifiers, and it will determine what happens after a certain period of time when they assess it for sensitivity. So the chemo drugs is a 6-day cumulative results, but the targeted drugs like the monoclonals and the small molecular weight, that's a 48-hour cumulative results. The natural substance is also a 48-hour cumulative results. That's the same. Targeted drugs, natural drugs. But the chemo drugs, the alkylating agents, the nucleoside analogs, all these are all a 6-day cumulative results. That's why they give such a high percentage, like 80-some%. Here, with this 48-hour, you'll probably rarely see anything over 45% sensitivity. Rarely. That's very high, by the way, efficacy.
Dr. Donato, may I ask a question now, or do you want me to wait till the end?
Go ahead and ask. This is Roundtable.
Okay, so in relation to this, the chemo drugs being done for 6 days and the others for 48 hours, is that based on like research into this, or I've been wondering why they do them differently like that. Is that based on research or their experience of, like yeah.
So now you are asking me beyond what I know.
Okay.
Okay.
All right.
So Dr. Bine, can you make a comment here at this point if there's any that is above this information to answer Dr. Wynn?
Yeah, we've not been informed on why their processes are such.
Okay.
Just that's what they are.
Yeah. Okay. All right. Well, when
Remember,
people ask me, I tell them it's because, I just say their research, which
Right.
could be, theirs. Yeah. So, okay.
they've done the research. Remember, they've been doing this since 2004. Okay.
Yeah.
So they have the system down. It's just gradually innovations and improving over time. Again, some of this information, the reason I don't have privilege is because it's proprietary. You know?
Sure.
That's it. That's all I can say. Now, thank you for asking that question, because now at least we know where we are. So, it is an ex vivo study, and it is.
May I say something, a little something?
Yes.
In
Yes.
relation to that question, I always thought of it like when you think about the different chemo drugs and how they have different half-lives, right? The platins are much longer half-lives. So if we're going to check the efficacy of a drug with a longer half-life, would have to incubate the cells for a longer period of time. However, with natural substances, this is all speculation.
Yes.
With natural substances, when I think about even how we dose, let's say turmeric 500 BID, it's a shorter half-life, and so you would need a shorter period to incubate and see if there's any efficacy in the cancer cells.
That's a fair
I
point.
agree. And I agree. The lab has figured that out. They have different ways of doing things for each drug, concentration and how they evaluate the results, and they could not give me any specifics. Unfortunately, I wish I could. That's one thing that Dr. Biden and I am trying to meet with the lab supervisor so that he can give us a little more insight so that I can bridge the gap. But you know what? Until that time comes, unfortunately, I don't have that information. Okay, but it makes sense. I totally understand. But they figured it out. So you have to apply it clinically and determine by trial and error or whatever we've been doing all this time, what we recommend, so that you'll come up with an outcome that's favorable. And I have favorable outcomes, lots, through experience. In the beginning, you may not now, unless you are Dr. Wyndham or other providers that have frequently met with me. You're coming out with results that I'm seeing already because I gave you some shortcuts to help you. Okay. So if you want to jump the gun and go to shortcuts, meet with me. I'll help you through this. Okay. So here in the assay procedure, okay. So cumulative results, testing it's in ex vivo, and for the monoclonal antibodies, It is a small molecular weight. It's a 48-hour culture. And again, they use cell viability by flow cytometry. They assess that. And then the classification now is different. If it's less than 5%, it's not effective. If this is 48 hours, okay, that means that after 48 hours, then they determine the efficacy. If it's greater or equal to 5%, it's sensitive. That's all. There's no high sensitivity. There's no partial. It's either effective or not effective. That's it. And that's the same information that you get when you order an extra substance that is additional to the routine test. When you see the report that says effective, if you want to know the percentage, you have to subtract the without substance from the with substance. And the difference, it has to be 5% or more, and that's what's effective, over 5%. Now, how you will say, okay, is the 8%, are we going to choose the 15% over the 8%, or does it mean it's still sensitive? Because some doctors have reasoned, that they're wondering about this percentage. Well, I'll tell you right now, in the logic, I'm going to use the highest percentage because that has the highest efficacy. Okay, as long as it's over 5%, it's effective, but I'm going to use higher than that. So for the natural substances, they develop 46 cell cultures in appropriate medium, and they add their biological modifiers, and then they are harvesting a sample every 24 hours to make the following assays. They measure the apoptotic activity or ability, and it depends on the substances. They measure the inhibition of tyrosine kinase catalytic activity from growth factor receptors. They measure the production of cytokines from the peripheral blood mononuclear cells. They measure the inhibition of the EGF, the epidermal growth factors, and the IGF, the insulin growth factors. They measure the inhibition. They measure the inhibition of the VEGF, okay, the vascular endothelial growth factors, and the fibroblast growth factors, and the platelet-derived growth factors, PDGF. These are all the angiogenesis, right, genes. They measure the inhibition of these receptors. And then they measure the catalytic activity of glutathione, the GSSG redox, and induction of cytochrome C, apoptosis, especially the caspase 3 and 9 pathways. And then it tells basically what natural substance will induce apoptosis via the cytochrome C after the CTC and single product have been in contact in a well plate for 48 hours. And the classifications then is if it's less than 5%, it's not effective. Okay, over 5% or equal to 5%, it's effective. So the protocol recommendation then, if you recall from our training, is you select one from each class. Class 1, Class 2, and Class 3. So Class 1 is cytotoxic, that basically kills cancer cells in contact in the well plate, okay? So there's a perfect scenario there. Nothing is going on, like in our bodies, it has to go through several biological transformations to reach target, but here it's already at the target. Shortcut, perfect scenario. You've got to figure out your patient's metabolism and deal with it. But we know it's going to work, okay? Class 2 is an immunomodulator, immunostimulant. So it's going to enhance the immune system's ability to destroy the cancer cell. Frequently, this Class 2 is negative. There's no sensitivity frequently. Unless it's melanoma, it's almost 100% of the time you'll see something. Okay, or some other very advanced disease like prostate stage 4, you'll see sometimes. But other than that, it's usually not any sensitivity there. Class 3, you're gonna see a lot. This is a protein kinase inhibitor or the growth inhibitors or or signaling inhibitors, all that is coming from class 3. So next time we meet, we will be covering the gene expression profiles, and that, keep in mind, involves class 3 a lot. Okay, so when you look at class 3, you're looking at inhibitors of a lot of these metabolic pathways or receptors. Class 3. So when you think of gene expression, think class 3. All right, so an agent is selected from each class. So if you don't have a class 2, then it's recommended you select 2 class 1s, that means 2 cytotoxics, and 1 class 3 growth inhibitor or signaling inhibitor or whatever is protein kinase inhibitor. So that's how you do it. 2 agents of class 1 and 1 agent from class 3 to make a group of 3. And this group of 3 is done 5 days on, 2 days off. Personally, I like to get the weekends off. Okay, so I had them do it 5 days a week. Now, you need to review your documents that I sent to you after the training, that live training for test interpretation, because there's other information there that I'm not going to cover because there's too many information. Look in them, for example, some interactions between agents. You don't want to combine certain ones together, and certain ones shouldn't be on the same day. It needs to be another cycle because they are interacting in a negative way. Also, how you interact these natural protocol to conventional oncology care is also another issue. So in general, don't have them follow the extracts protocol on the day of chemo. Take them off that. Don't do anything on the day of chemo just to make sure. In general, okay? So the person is getting infusion every Wednesday. Well, Wednesday, these guys are off. They're just doing their dietary, their lifestyle, fasting, whatever they're doing to improve the chemo outcome. They may be doing a fasting that day. So whatever it takes. Now, after 3 months on the treatment protocol, let's say they're doing a 1-month rotation. After 3 months, then they have to go through a waiting period. So you have to educate your patient. They need to stop the protocol schedule for 2 weeks prior to the scheduled blood draw. Otherwise, they come to your office and you ask them, have you been off the supplements for 2 weeks? No, I took it yesterday. I'm sorry, I have to reschedule you 2 weeks later. Okay. Now that patient will not be happy, but you're saving them from an erroneous result because it costs so much money to order these tests. So they will swallow the pride and they will say, yeah, I guess you're right, because I don't want to pay for something when it's inaccurate. Okay. So you have to take them off, and they should already know that in advance. I'm going to be off my therapy protocol. I'm finishing my 3 months. I better let the office know. I need to be scheduled for a blood draw. I'm now at the finish of my 3rd month, and I have to be off for 2 weeks. So I'm stopping now. Call the doctor's office. Hey, schedule me for a blood draw 2 weeks from now. Okay? You have to educate them. And also, not everything is 2 weeks. Some drugs, targeted drugs we're talking about, they have, you can actually choose a shorter date, but you have to have knowledge of the half-life of the drug. So look at, if I were you, I would download Medscape app. I use it all the time. It shows the pharmacology of the drug, and it tells you what's the half-life. And you figure out the half-life, and you multiply that by 5, it might end up only being 3 days. The patient will not panic. Hey, doc, I have to be off this drug for 2 weeks? My goodness, I mean, the cancer is going to explode. No. My experience shows that the cancer doesn't grow that fast. If they grow that fast, we will never stop them. Okay? And I get good results. So no, you're not going to get that. What you're going to see is that it will be accurate information. And also just keep in mind that you will need to look at the half-life and multiply by 5, because if it's 3 days versus 2 weeks, that's a happy camper. Or 5 days or 7 days versus 14 days. That's a big difference still. Psychologically, anyway, to the patient.
So I have a question.
Yes.
So
Go. Okay.
so the 2 weeks that they would have to be off for the 3-month follow-up for the OncoTrace test, will they have to be off of any of these natural substance protocols, or can they continue to still have the natural products up to the time of the OncoTrace?
If it is not a class 1 or a class 3 agent, yes, they can continue. But if it's labeled as a class 1 or class 3, or as if sometimes you're using supplements that may not be listed in RGCC, but you think they might have a direct effect to the cancer, it's better to stop it. Or look it up online, but you're not always going to see it as nice as a drug, where the drug tells you what the half-life is and what it does. You may not necessarily, there's a lot of overlaps. To be in a safe side, if this patient is taking a high quantity of natural substance, you better say, it's better if you just stop it, just in case it's going to interfere with the CTC detection.
And how long would that be for stopping it?
14 days, 2 weeks.
Okay. So question then, if I have a patient, which I do, that is trying to get the test taken and the results back before she's scheduled for surgery that she does not want, because she wants to see how this protocol has worked, she did not go off of it for 2 weeks, but opted to do the blood test like a day ago. So now, what would I tell her when the test comes back?
Oh, you mean she went ahead and did the test and you didn't know that
No, I
she
did
said,
know. I did know, but I didn't have this knowledge right now.
okay, then it is your duty to state that whatever you see in this result may not be accurate. I'll do the best I can with this, but you did not follow the 2 weeks of being off of that schedule that we discussed at your initial consult. So I'll do my best to interpret this, but it may not be accurate.
Okay, so this was more on me than on her, because
Yes.
I did not understand that she had to be off
Right.
of the protocol for 2 weeks. I thought she had to be off
Right.
the drug. So anyway,
All
Dr.
substances.
Yeah, I
Dr.
have a-
Donato,
Yes.
I found that if you do something like that, if you get a hold of the RGC info and the med lab, you can cancel the test. They would refund the money, and then you can redraw the blood test in 2 weeks. So
Right. If you are in that window, as long as the test kit has not gone out, you might just be responsible for the test kit that they will not refund to you, which is about €100. So the rest can be refunded. But if you haven't yet provided the kit, then they will likely receive everything back, refunded. So there's a timeline that you got to observe in your blood collection as to when is the 100% refund and an 80% refund and all that stuff. You have to look at it.
Doctor, can you hear me?
Yes.
Okay, I have a question. You were telling if the patient is in the protocol, if they are getting simultaneously the treatment with a chemotherapy. In my understanding, when the patient gonna to draw blood, if the patient is getting chemo, the patient need to be off per 3 weeks, 21 days. In the case the patient is doing simultaneously the both treatment, the RGCC protocol and the regular oncologist protocol, if the patient, in this case, you are telling us we need to wait 2 weeks to reduce the blood. But if chemo is using in the middle, we need to wait 3 weeks, right?
Yeah. So you first determine the chemo drugs. It depends on which chemo drug. If it's a platinum derived chemo, it's 3 weeks, 21 days. If it's a non-platinum, it's 2 weeks. So once you calculate the date, you just go backwards 2 weeks if it's natural substances, 3 weeks if it's chemo platinum, and that's how you tell the patient, okay, now you stop. We have to make sure that your last chemo session is going to be this date, and so that our draw is this date, and then you have to coordinate that with your natural substance too. And again, if there's targeted drugs involved, same thing. You just have to also calculate the half-life. That maybe it's just shorter. So every agent might have different timing when to stop it before that scheduled blood draw. Did I answer the question?
Thank you. Yes, thank you.
Okay.
So one last question then for me, and that
Dr. Hickey.
is, yes, so if I'm going to go ahead and let this test be shipped off and tested, okay, because of her timing, am I looking at some kill off or something like that? Is that going to keep the CTCs up higher? Is that the idea?
Okay, let me ask you the question. Was it the OncoTrace or was it an Onconomics Plus? Which one did you do?
Okay, I did the OncoTrace.
That's the test that you had done, is the OncoTrace test.
Yeah, that's
so
the follow-up
if that's
test.
if that's the case, then you are encountering this 13.8% false negative of the OncoTrace. Okay, so in that 13.8% false negative, that's where if this person is receiving systemic treatment, which is in this case, your CTC number, if it's even there, will be lower than expected or higher than expected. We can either go both ways. And the reason why is if the tumor mass at the time the test was done, drawn, if that day somehow or within the last 24 hours, if the mass ruptured due to chemo agents, there will be a lot of CTCs in the bloodstream. If the CTCs in another scenario, if the CTCs in the bloodstream were whatever it was, and they're getting chemo treatment, it will be less than what it normally would because it's destroying them in systemic circulation. So you'll have a lower number than expected. And sometimes it's 0. That's why you get frustrated because this person has a stage 4 cancer with 0 CTC. And usually you can tell because in the report, if you look at the biomarkers, you'll see CD31 positive and pan-CK positive or dim. That has to do with more of a contamination. But if they're not positive, those two are not positive, then, and you still have 0, which is unexpected, it's because of the timing of the blood draw. Okay. And that's why you have to follow that time period to detect CTCs because they're destroyed.
Yeah, and I understand that. In this particular situation, she is only taking the cytotoxic and the PK inhibitors. Okay, so she's doing that. She's not doing any chemo, and and so I was not aware that she needed to be off 14 days even for that. So that's where she's at. She's not she's not on chemo or anything else.
Yeah,
that's where she's at.
Well, after the fact, yeah. So you just have to let her know that this may be lower than it should be.
Okay.
Just the likelihood is it may be lower CTC than it should be. So the next CTC testing, which OncoTrace, 3.5 months later, will hopefully realign you back to where it should be.
Okay. Thank you.
All right.
While we're still on this page, I'd like to ask a couple questions.
Yes.
One is this 5 days on, 2 days off, when people are on the rotation of those agents. I haven't been doing that. I've been doing every day for a month and then they rotate on to the next one. Is that 5 and 2 pretty important? I'm wondering if I should call all my patients and start having them do that.
Yeah, I've done that, Dr. Wyndham. It's really a recommendation from RGCC. How they came up with that. Probably Dr. Blind, you can make a comment.
I was just going to say, I don't rotate them off weekends either. Generally, that was back when we used to do a rotation that was like 2 days of each substance. And it kind of worked out where we could give them a 1 or 2 day off just because they were only doing back to back. But it really does come down to preference, the state of your patient's health, how hardy they are. Some people really need the break. In the era of these super cancers we're seeing, they're so aggressive. They're progressing faster than we used to see. I feel like cancer doesn't really take a break. So I don't really feel comfortable letting the patient take the break. But once again, RGCC doesn't tell you how to practice medicine. They give you the guidelines and, you know, the base education, but from there you kind of adjust this to what works for your patient base and in your, you know, particular belief system.
Okay. All right.
And
And
Dr.
then-
Donato, go ahead. Dr. Donato, one thing that I do, you know, and I agree with Terry, it depends on the patient, what they're able to do, their state of mind, etc. But if I don't rotate, but I have them take a day, if their ascorbic acid is high and they can't afford the IV infusions, which are the best way, but if they can't afford them, then I have them take a day off, but that day off, I have them taking liposomal C like every 2 hours until their stomach or their bowels tell them they can't. So that's kind of like an oral IV day for vitamin C.
That's an
Thank you,
intriguing.
Dr. Solomon.
Yeah.
Yes.
It's a good idea.
You've got some very experienced practitioner telling us that. That's wonderful. Thank you.
I have one more question on this page. You said some of the natural products can interact with each other, but what is I look at the biomarkers reference guide, but where is that information for what could interact? I was just looking online. I don't see where that is.
Yeah, that is in one. There's a document in one of the 30 documents I sent to those who completed the test interpretation. One of those documents show an example of interaction. That's the one that you should reference.
Okay, in an email from you, I should look for it.
If you have any questions, send me an email and I'll send a document to you. Send it to support and then I'll send you the document. Okay.
Okay. All right. Thank you.
For example, you know that genistein and quercetin shouldn't be together. Okay, that's an example. Okay. Yes.
Dr. Donato, I have a
Yes.
question about mistletoe. So there's patients that are very interested in mistletoe, but it never comes up. And RGC only tests for one type of mistletoe, right? So would you say in general, just mistletoe doesn't have a big role in the treatment of cancer based on the test results?
No, it does have a role. It's just that if you have a different type of mistletoe, please send that in as an additional substance or test so that you'll know for sure if it works for you. But I would recommend that when you do a additional substance testing, because that's free for the first 5 for all Onconomics.
Yes.
I would recommend that you classify them as class 1 and class 3 because it's already tested as a class 2. But if you have your own substance to test, then you better put down class 1, class 2, and class 3 in 3 separate lines. Because RGCC just tested according to what they have in their own criteria, determine what class they're supposed to be. But it doesn't mean it won't work as a class 1 or it won't work as a class 3. You just have to test it to figure it out.
Okay.
Okay.
Dr. Blom, also
Yes.
mistletoe is one of those that really does well in the human body, and it has often a ramp up time and it to build up. So it might be one of the products, all labs have limitations, and it is one single dose to see if it induced apoptosis. So that might be one of those supplements that, you may not throw the baby out with the bathwater based on those results, because most mistletoe is a step-up process. It is very specific to the type of cancer, and it really does need the host of other functions in the human body to do its job. Does
Okay.
that make sense?
Yeah, thank you. Okay. Yeah, I got a lot of information from the what's it, the anthroposophic organization, and they have recommendations. Certain types of mistletoe are good for certain types of cancer.
Exactly.
So yeah.
This is very much generic testing, and back to it's one single dose. And I do believe there are certain substances that really do need to kind of ramp up and build up in the body to start doing its job. And I think mistletoe falls in that level of need to really judge it fairly.
Right.
Thank you.
One of the things that you guys need to keep in mind is that because natural substances have broad effects, and also they are not created equal, there's no standardization like it is with drugs. It's not FDA approved. So you have to keep in mind that if you want consistent results, use the one that's recommended by RGCC. And it's in your documentation, the ones that are listed with links in there or with reference. Use them because they are the ones that we've been using all this time. Don't just pick your own agent just because they have the same name, a different brand maybe, but don't point at us and say, hey, how come it didn't work? Well, are you using the ones that we're using? Keep that in mind, okay? Because every company says they have a high purity standard, blah, 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 but it's not the same. Who's going to police them and say, hey, you need to follow this guideline? Who's going to watch over them? You can't rely on that information, okay? So use the ones that we use, and then more likely you'll get the results you're expecting. Okay, so if you don't have that copy, you should be able to reference that in your portal. You can download it from your portal. If you don't have that, if you don't see it, just let us know in the clinical support. We'll send you a copy.
An interesting question would be, maybe in September at the meeting, would be how often does RGCC retest and update their supplement, what's in them? Because, companies change recipes, so to speak, and some of our companies like Pure Encapsulations are now owned by Pfizer, and it's a concern. So I'd like to know, plus we have the Thorn artemisinin is also discontinued for well over a year, well over maybe 2, I don't know, lose track. And, they need to update that because you can't even buy it anymore.
You're right. We tried to tell the lab, Artisan is the one you're referring to, but they're unfortunately it's still there. But yeah, at the next time when it's time to update, I'm sure they'll remove it if we keep bugging them about it.
Yeah, it'd be nice to know though how often they're retesting their stockpile of supplements to see if they're still effective. So
well, when I joined in
2008.
When I joined in 2018, they were using it the same thing until just a few months ago when you saw that change. So it took several years before they changed their product or add new ones and remove the other ones. So anyway, that's not my department. I'm here as a clinical support here. But yeah, that's a good point. Okay, so if you guys don't have any other questions, let's take a look at a case example here. Okay, so I've got this patient, and you can interrupt me anytime, and then we can answer some of your questions also. But I'll make it as quick as possible. Yeah, go ahead.
Is there a document I've been looking through that shows what the substances are and what class they are? Because when I go to like a different supplement, like let's say a patient is on ESIAC, and I'm not sure which class it is, and I'm trying to delve into research, and there's not much research on many natural substances. Right. Is there a document that RGCC has that says the ESIAC? We know it's a class 1. That way I'm not guessing or putting the wrong class on a...
I see what you mean. Yeah. I don't know of any. And so what I would do is when you are anticipating or ordering Onconomics or Extracts Plus or Extracts, make sure you put in your 5 additional substance, your SEAC as a class 1, as a class 2, and as a class 3. And then the results will tell you which one it is.
Understood. I didn't realize you could do multiple classes for one substance. Thank you.
Yes, right. Of course, it's going to take your 5 spots, but you know what? If you really need to know, that's what you have to do.
Wow. Okay. Thank you.
You're welcome. Okay, so if there's no other questions, here's a case example of a management I did, and I chose a complex one. This is the stage 4 left breast cancer, invasive ductal carcinoma, and the right breast had DCIS. This is ER positive, PR positive, HER2 negative, status post left axillary sentinel lymph node dissection, and bilateral partial mastectomy. And that was back in 2017. And then presented with low back pain and found out there's bone mets in the L4 vertebra. And so this person also had some mets in the hip and sternum and lung. So this is an advanced disease. And that was the original date of the diagnosis, and the surgical report is right here. And again, this is advanced. And so this person came to me and then wanted to see if there's any natural approach to this. And so she was at the time on letrozole daily, and also was getting palbociclib. And so also, just a conventional recommendation for oncology for this patient based on her situation. And so this is complex. This is something that I had to work in and to accommodate for that and create an integrated plan. So, just so you can look at the full view of this spreadsheet. I'm going to see if it works here. Hopefully, it'll open up in Safari. Otherwise, I have to open a separate window. Okay, I knew this would happen. Okay, so I'm going to go ahead and open another document here that is showing the spreadsheet. And I'll just share this in a different screen here. All right. So here's the spreadsheet. So in the first year, I got to know about RGCC in 2018. So I didn't really do much about it for the first year, but I did eventually order the RGCC. But here is March 13 of 2020. So I saw her in March of a year prior, 2019 is here. And a year later, finally did the OncoTrace and the Onconomics Plus. That's our baseline. And so we are responsible here at this point to talk about the Onconomics Plus extracts or the chemosensitivity. We'll talk about the gene expression next session. So ignore these this spreadsheet is comprehensive. I look at a spreadsheet all the time because it helps me determine what's my next move. It's like a chess game. If you don't know what you did before, you're not going to know your next move. You got to have a spreadsheet. Okay,
Dr.
however you
Donato,
create a spreadsheet. Yes.
do you create this spreadsheet? Does your staff create it, or is this something that RGCC provides when you do multiple tests on the same patient?
No, this is my own spreadsheet. By the way, I have a few colleagues here who are like me. We're Gerson practitioners, and we use spreadsheets all the time. But if you want a kind of like an empty spreadsheet and you want to modify it yourself, let me know. I'll be happy to send one to you. Okay, a generic spreadsheet.
Okay.
All right. Send your email to support. Okay, so here we have the OncoTrace and Onconomics Plus, and you can see down here under class 1 and class 2 and class 3. So I look at all the sensitivities that I'm going to be using, and I highlight them so that the next time I do the Onconomics a year later, it may have changed and I might discontinue it because it's no longer sensitive. Because these cancer cells are mutating and developing secondary resistance at the same time, and you're not going to see consistently the same sensitivity. I guarantee you, after 6 months, there's going to be a question there. And that's why the CTC numbers do not continue to drop through the whole year. They will level off somewhere after 6 months because they're no longer sensitive. No matter what you do, they're no longer sensitive. So you might as well order another one. It all depends on the MDR1. If the MDR1 and the MRP are very high, I guarantee you after 6 months, more than half of your agents no longer are good. So that's why it's recommended you order Onconomics every 9 to 12 months. Okay, every 9 to 12 months. Your OncoTraces, OncoTrails are every 3.5 months. That's when you get the blood draw. But really, it's you got to work like clockwork if you want to get the results that you're looking for. So you can see here that under the small molecular weight drugs, because this patient is not on chemo. This is targeted drugs and natural substances. You can see I've got them all here. The aromatase inhibitors. We've got the CDK4, CDK6 inhibitor, palbociclib. You see it was 0, and yet at one time she's been on it. So, you know, doctors don't know. Oncologists don't know whether it works or not. They're just assuming it will. And sometimes it will flag 25%, and some other years it'll be back down to 0. So it kind of goes back and forth. So again, they don't really follow this system anyway. So whatever they're doing, you just monitor it. But from your end, which is controlling your natural substances, class 1, 2, and 3, you can see there's no class 2 here because nothing flagged on class 2. So I'm just looking at class 1 and class 3. There's no class 2. So it's still here, but there's no sensitivity. So I select the highest percentages and work down to the lowest percentages. So the highest percentage should be your first month rotation. The next highest will be the second month, and the least highest will be the third month. Now, if you have a lot of them, 30% or more, then use them all, and that would be all 3 months. That would be a perfect scenario, but it's not always that case. And you can see every year it changes. Like for this one, the agaricus, for the first 2, it's still okay. Then the third time I did Onconomics, it's only 5%. So I got to change, okay? So you always have to look at this and make adjustments every year to create a high efficacy protocol. And you can see here, this patient started out at 6.6. Now that's over 5 for a breast cancer. Less than 5 cells per 7.5 mil is the cutoff. If it's over that, it's considered advanced disease. Okay, so this woman started at 6.6. She's now down to 2.6. But I had to have her get SOTs to drop it this low. It's not easy. This woman's cancer is very resistant. So what I did is I recommend SOT. Now, I don't do SOT because I'm a telehealth provider, okay? So I send them over to a RGCC practitioner who has an office that does all the infusions, and both of us now are managing the case. This doctor is just doing the infusion part because I don't do that. But with good communication, this patient is receiving SOTs, and it was determined by this other doctor that this woman has EBV. So you can imagine now that there's some other issues going on that was causing this patient to have a resistance because there's a viral issue. So it went down from 6.6 to 2.5. That was my lowest. And then it jumped to 3.4. And I couldn't understand what is going on here. And so you can see that the subpopulation was obviously the EpCAM positive cells. They should be going down too. But look at that 1.8, it jumped up to 2.5. And then from 2.5 on the CTC, it went on 3.4. Now, at this point, I said, okay, something's going on here. And I made the modification of the protocol. And then eventually I ran an Onconomics Plus. That was, this is the same years, because when I saw this, I said, hey, something's going on. I need some new agents here. So I went ahead and ordered an Onconomics Plus a month later. And you can see that even that change of barely a few weeks, the CTCs already jumped to 4 from 2.5, this EpCAM positive cell group. And then the CTC went from 3.9 to 4.9. So at this point, I knew something's going on. And so I went ahead and redid her protocol with new sensitivities. And then what I did is I also had this patient At this point, I realized that maybe there's some other issues going on here that may be viral situation. So I sent him to this RGCC practitioner who has a lot of background with non-cancer cases, not just cancer cases. And so she figured out this person had EBV and went ahead and ordered an SOT for EBV. Okay, and so when she did that, the next time I saw her, it dropped from 4.9 to 3.2. So, well, that same year, though, she received not just the EBV SOT, but she also received the cancer SOT at the same time. So she got both. So that's SOT in August of 2022. This was July. So by August, she received 2 SOTs, one for virus and one for cancer. And the next time I saw her on March 10 of the following year, it was down from 4.9 to 3.2. Said, wow, this is amazing. This is great. Remember, your goal is to get it below 2 to reduce the risk for future disease progression. Very important clinically. Once you're less than 2, you get it down to less than 1.4 or less to be in the territorial level of remission status. That's the goal of all RGCC practitioners. Okay, so she got down to 3.2. Then at this point, we went ahead and continued the therapy. And then in October of that year, I did the OncoTrace and it was 3.1. I said, my goodness, it's not budging again. It went from 4.9 to 3.2, and then from 3.2 to 3.1. And I thought, oh man, something's wrong. So at the same time, since it's almost a year, actually it's over a year, I went and ordered the Onconomics Plus also, and redid the protocol. And at the same time, this was October, and in June, this was June of that year, that same year after, let's see here, this is August of 22. In June of 2023, prior to her visit with me, she had received one SOT and it came out to be 3.1. So it looked like it didn't make a difference. In other words, it didn't make a difference. It was still in the 3 range. So I ordered the Onconomics Plus at the same time that I did the OncoTrace, and I redid the protocol. And then in April of 2023, that's before I saw her in June, she received another cancer SOT. And when I saw her in June of this year, it was down to 2.6. So she has received a total of 4 SOTs. 1 from viral, and that resulted. They did the viral testing. It resulted. So she didn't need any more viral SOTs, just the SOTs for cancer, and this was the 3rd SOT for cancer, and it's down to 2.6. And the subpopulation went from 2.4 to 1.9. So you can see here that you have to coordinate with infusion therapies when you have to, and of course to determine if the patient is a candidate for that in a safe manner, you have to have a scan, at least a recent full body scan, to determine the total dimension of the residual tumor mass. Because if it's over 5 centimeter, it's not recommended. In fact, it may be contraindicated to order an SOT or cell therapy because the risk for tumor lysis syndrome is going to be there, and you don't want that risk. So total dimension, meaning if there's several lesions, you have to add them all up. And I had to reject a patient this week for SOT because it was over 5 centimeters. And she said, oh, I wish I could have that because I don't want to do surgery, please. I said, no, you don't meet the criteria. You need in this case, actually, chemo. She doesn't qualify for surgery. You need chemotherapy. We got to lower the tumor mass first. After a few sessions of that, let's have another mass, let's have another scan, and let's look at it to see if you qualify.
So Dr. Donato, I'm actually doing one of these where I'm ordering an SOT on a patient, and she has AML with a CTC count of 2.1. And I ordered the SOT. We just ordered it yesterday. I don't even think it's actually ordered yet. We just started the process yesterday, and
yes.
I don't even think so. I don't think it's actually ordered. But my understanding, I just want to make sure that I'm thinking right. That because it's a hematologic cancer, I don't have anything to measure mass, but her blast cells are going up, so it's getting worse, which is why we want to implement the SOT, even though she's not even fully on the RGCC protocol yet. But since her CTCs were below 5, I was thinking that it would be okay to implement it. Would you agree with that? Is that right?
Actually, it's better to be closer to 2, because 5 or 4, that's still considered high disease load.
Yeah.
It needs to be closer to 2. But I'll let Dr. Baim answer this question, because hematological, what do you think, Dr. Baim?
Absolutely.
What she's saying correct?
You can absolutely do it on that. And even the count, I've done a ton of SOTs on higher CTC count, as long as their tumor burden is low. Because our biggest concern when you do an SOT is tumor lysis syndrome. Now, we have lots of providers that are comfortable. They're ER, they have privileges, they'll handle it. So they might still choose. Once again, RGCC doesn't tell them how to practice medicine, but they're prepared to handle the tumor lysis syndrome. Generally speaking, you're just looking to see, is it safe to infuse? And in that case, you're not looking at a big concern of overwhelming the body with die-off, because that's really what we're talking about. And there's key areas that you always want to be concerned with, specifically lung lesions. And I saw one of the questions, and if it's 5 centimeters, one single lesion, or it's a one single where it's 5 centimeters or larger, or do you have multiple that add up? Because it's all about, is the die-off going to overwhelm that person's body, and then you end up with the TLS, which is your concern, and trying to avoid that.
Okay.
That help?
Yeah, it does. I'm gonna have to get I'm gonna have to call an oncologist friend or something like that, because I read all the material on SOT from RGCC. I'm just not quite sure how to handle tumor lysis syndrome if I see it, other than, I don't even know if steroids work.
We have a lot of literature I can send you. Just email me on tumor lysis. But honestly, if you're not if you're not in that stage of handling it, you're better not to do it. Because it is going to fall on you, and you are going to get that call from the ER department saying, what did you infuse to my patient? And that's obviously not what most doctors want, position they want to be in. So when in doubt, don't. But you can always set up 2, and we can do a case review. Just use the a consult link, and we can walk through what that patient's scenario is to see if it's really in their best interest or not. Safety at all costs.
Okay.
Just so you know, 95% of my cases do not do infusion therapies, and I'm getting the results I'm looking for. I only use the infusion therapy as a final. If I'm not budging it, no matter what I do, then I do the SOT, and it's much safer, because by that time the tumor burden is very low, and they get a much better outcome. And as far as how do you get that, that is an advanced training you're going to need to look into later on. We can offer that, but not for this purpose. This purpose is the timing and when to do it is very important, because once you have that SOT in your system, it works 24/7. You can't stop it. It's just keep killing. You can't stop it. It's too late. So better to be safe than sorry later on. That's all I can say. Okay, because it's very powerful. Now, there's some questions here that maybe Drs. Baim can answer. Something to EBV, IgM, or IgG. Okay, well, this particular case, I would have to look it up, but I think it was IgG active. And then the other one is why didn't she get a VaxSecure? Well, okay, so again, it has to do with cost. Okay, your price for the VaxSecure is like $7,500, but this patient would have to pay for your admin fee Who knows how much, but some clinics are charging $16,000 to $20,000 for these 3 infusions.
Of
It just doesn't have that money.
of what? Of the SOT?
No, Vaxicure.
Oh, yeah. Okay, the vaccine.
Yeah, the vaccine. It costs about $16,000 to $20,000 depending on which doctor office you go to. So she just didn't want that. She lives in a big city, and all those doctors there are charging high, really high. So she would prefer not to do the Vaxicure, but that could be a good one. Sure, if you can convince a patient to get that would be great. Okay, so at this point, we are now 5 after the hour. So I am very amazed that all of you are here, towards 25 and here. This is great. We should do this and talk this through, because I know you're searching. I know you want good results, and I'm always hunting for good results. But my background is a little bit different. It's more on the lifestyle, dietary manipulation, and all the extracts. I'm not into drugs, although I don't oppose it. It's just my background. But we're all RGCC practitioners, and we need to know what works and what doesn't work, and coordinate the care. You're now in charge. The oncologist is now doing a task that is part of your realm, because you are the one in charge. They are accomplishing an adjunctive therapy. Chemo drug, adjunctive. Yours is you're in full control. You oversee, you know what works, you know what doesn't work. And if you can't control what they do, oncology, don't worry about it. You can still control everything else around that and make things easier on the patient, reduce their toxicities, and deal with it. Okay? You'll get good results. This patient is getting the best of both worlds. Think about that.
I have a question. When would, if cost is not an object, when would you do the immune vax or the other therapies RGC offers other than the SOTs? When would you step up? And
well,
is
it
there
all depends.
a limit on how many times you can do the other therapies other than the SOT?
Well, Dr. Bynum can probably answer that question if you care to.
Understand the nature. They're different animals. So we have the Onconomics plus testing, which is telling us what the cancer is capable of, right? All its hidden things that it can do. So we can interfere with those abilities and then implement things that work to downregulate tumor genes, kill the cells, all that. Therapies come in complementary to that. So we have SOT that is working to silence. It's interfering with that cancer's ability to keep replicating. Okay. But it works, and it works for 6 months. But when it's done, it's done. Immunotherapies are building memory cells. So those are long-term benefits, because once you get the cancer to be recognized by the immune system, now the immune system carries that on. I've seen patients keep their memory cells for years and years and years until some event happened that caused a plummeting of them. So they're not exclusive. Everything is very complementary. In fact, an SOT prior to an immunotherapy can be very beneficial because it can release extra epitopes. We can get a more robust response just by releasing that additional material into the bloodstream. So each person's going to be unique in deciding when and how and if even. Sometimes it's just not a good idea that the cancer is too advanced, the patient has an autoimmune, or their inflammation is through the roof and they're just not going to respond. So this is where the uniqueness of RGCC comes in that there is going to be no do this for everybody, right? So
I mean, RGC is, and if you're doing it the right way, it's basically an individualized care plan for every patient. Lifestyle, RGC, your medicines, all the other arrows that you can shoot, so to speak. It's got to be individualized. So
correct, 100%.
Okay, well, thank you so much.
You're very welcome. Don't take lightly the extracts protocol, because that in the long haul is going to be the long term. It's very effective if you use it correctly and the right order, and also watching that spreadsheet watching the changes and creating different scenarios to achieve that same linear decrease on CTCs. So I've become really good at that because that's what I do all the time. And so, like I said, don't take lightly the extracts. If you're not getting results, I had one doctor contacted me and he's done over 20 SOTs and the numbers are over 2. And I kind of wonder, what in the world's going on here? Well, you have to realize that, are you really using your extracts protocol or are you just jumping to SOT? Some doctors order OncoTrace and then straight to SOT. They're not even doing Onconomics. What in the world are you thinking? You think SOT will do the whole work? That is an icing to the cake. That is an adjunctive. That is something that's extra. It's not a standalone, just like Dr. Biden was saying. It's not a standalone. The one that can really work are the extracts protocol, the dietary change, all your background in functional medicine. That's it. But you are pointed to what is going to work without the guesswork. Okay.
So how
if you
do we
just follow
find
that
out?
and be consistent, you'll get results I'm getting.
So how do we find out? You've mentioned to me several times. I bet other providers have the same question. Which of the natural products are, quotes, stable and which ones are unstable? Because I think you picked the unstable ones first. How do we find out that is, or is that just comes with experience and getting consults?
It comes to experience. It comes to experience. That's it. I can tell you one thing. Vitamin C is relatively stable. Epigenin is very stable. And I can tell you that agaricus and oxaloacetate and superartemisinin are relatively stable. But the one that's not stable at all, I can tell you right now, the one that's not stable is lycopene and also the cordyceps. These are not as stable. So you want to use them up first, if possible, at the highest. You kind of learn along the way. So how I select will be a little bit different from what's recommended because I'm thinking of stability. What's going to be 3 months from now or 5 months from now? What's the likelihood? Then I have to reflect my mind back to MDR1, MRP. So, okay, I bet I'm not going to be using this much and it's good anymore. So I'm going to have to change. I'm anticipating all the time. And so it's like this game, Mastermind. Have you ever played that? The little pegs that you put in Mastermind? How many rows does it take to figure out what's on the other side? I love that game. I just love it because I'm anticipating ahead of time what this guy put behind that block. So it's one of the things. You use the tools and be creative with it. The lab will not tell you what to do. They're not going to tell you how much to use. No one will tell you anything. You're the clinician. You figure it out. And we've given you some guidelines. And if you have no clue, there is some kind of starting point. We'll help you. Just contact us at support. Okay. So
thank you very much. This
is wonderful. I'm glad you guys came.
I want to say one thing, Dr. Donato, and this is kind of uncomfortable for me to say, but I sent a patient, because I don't do SOT, I'm telehealth, and I see patients in the office as well. I sent a patient to have an SOT done in another state, and the staff on hand told that patient, oh, we don't need a new blood draw, we can use your old one. And it's like, please educate staff on RGCC and the qualifications so they get the right information, because I feel like I'm having to, if I ever refer, I feel like I'm having to what's the proper word? Just manage that case to make sure it's done properly and educate the patient on how it's to be done so that the office I send him to with the money they're spending doesn't, give them wrong information.
For sure. This is what I do. When I have a OncoTrace that's only 1 month old, and I let the patient know, hey, this is you're a good candidate for SOT. Go ahead and contact so-and-so or call the admin office, our admin office, and they'll guide you to the nearest practitioner office that does SOT. Go ahead and contact them and see one of the practitioner to order SOT. And if you want to use your sample, that practitioner needs to send me the order, and then I will submit that order to the lab, and the lab will reference my sample, the patient sample, under my name, and that's how they'll run the test that is under my name, because they will not find this patient. They will just say, where's your sample? So send me the order. and then I'll send it to the lab, and the lab will say, oh, it's Dr. Donato. He had this oncotrace done a month ago on this patient, blah, blah, blah. And now they're going to run the test from that order, from that sample. Otherwise, they have to submit a new sample. But yeah, we train a doctor. These doctors know that you shouldn't be using samples that is over 6 months old. And I think that Dr. Bime said 3 months is pretty much the farthest she would go.
For
It's the
cancer.
cutoff, 3 months. Yeah.
For cancer.
So for cancer, okay. So anything that's older, get a new sample. You just never know. It's just a common sense. I won't pay $3,000 for an old sample because that's not. I don't even know if the target is still good. Okay, so just keep that in mind. And otherwise, that's how we do it. That's how we coordinate. Is the doctor sends you the order and you submit it if you're going to use the same sample. Otherwise, they need to draw the blood to do the SOT. Okay, it's 15 after, a quarter after the hour. So I think we're pretty much done, and then we'll meet next time, and we'll talk about the. Just keep in mind that chemosensitivity is that's your first and most important tool. You need to go by that first thing, and then if you want additional customization, you've got to know the gene expression rates, because the gene expression profile is to add more on top of what is already going to work. Now, some of them are already using. Some of them you may not have tested. Untested agents can still be used, but I'll help you there because some of these agents have already been stated in the biomarkers reference guide. But you're going to use that as a layering to address specific gene expression that you're trying to downregulate on top of the chemosensitivity results, and that will give you additional customization. And a lot of conventional doctors are doing that already. They look at the DNA study report and they look at the gene expression, and then they're trying to use a drug that's approved by the FDA to address that. But it's only one portion of the entire realm of genes that we're looking at. So we're seeing more than these guys. And so you're trying to get the best outcome. So the layering is the key for the gene expression. And also you'll know that certain genes are more expressed than others, and you're going to target those ones because those are the ones that are probably running the show. So anyway, we'll talk about that in the next session, and that will really help you. And finally, this fall, in October, we're going to have, hopefully some of you have signed up for the RGCC Mastery in Denver, Colorado. We'll meet each other there in person, and please sign up. You should have gotten the newsletter this week. It came out. Denver, Colorado, October, we'll meet. Okay? You guys have a good day. I wish you the best. Thanks for attending.
Thank you.
Bye, everybody.
Bye-bye.
Appreciate it.